Hi, and welcome to the podcast, The Science of Depression. My name is Lee, and I'll be your host for today. I'm a student at Arizona State University studying astrophysics, and this piece is for my senior thesis on science communication. The goal of this piece is to create something that can help either those with depression or somebody who knows somebody with depression kind of understand what depression is and what's happening. To that extent, I've invited two experts to talk with us today. Dr. Luaces, would you like to introduce yourself?
Yes. My name is Lorenzo-Luaces. I am an assistant professor at Indiana University, Bloomington, and I'm very generally interested in depression. A lot of the work I do focuses on either the diagnosis of depression and how heterogeneous it is, or different aspects of the treatment. Within the treatment, we especially study interventions that are psychological so that, they don't involve taking medications. They're about doing things differently, looking at the world from a different perspective and trying to learn skills. And I especially, because depression is a really big public health problem, I especially care about interventions that could be cheap or easy to disseminate, or that could be disseminated or given to people at a large scale.
That's great. Dr. Sydeman, would you like to introduce yourself?
Sure. So I am Sumner Sydeman. My doctoral degree is in clinical psychology, and I am a professor of psychological sciences at Northern Arizona University. So depression is an area that I have studied in my lines of research associated with health outcomes, and health-related behaviors. So for example, there is a high prevalence of depression in individuals who have coronary heart disease, so for example, who have survived heart attacks. And in addition, my research is also in the area of health behaviors like nicotine use, cigarette use, vaping use, and examining the association between psychological factors, including depression, with those behaviors.
The research for both of you sounds extremely fascinating. I'm very excited to hear more about it. First, can one of you or either of you explain a little bit about what depression is and a little bit about the symptoms?
I can take that if you want me to. So I usually think that when people use this word depression, it can mean one of two things in my mind. It can mean when you're only talking about your mood, right? So you could say, I'm depressed, right? Meaning that you are feeling sad, that you're feeling down, that you're feeling empty or hopeless. And so that could be like, I could say something that could, right now, that could cause you to have depressed mood. So that could be a way of talking about depression. A lot of times in clinical psychology, when we're talking about depression, we mean a depressive disorder, a diagnosis that a mental health professional would give you. And there's many different diagnoses that fall under this umbrella of depressive disorder. The one that people usually talk about, because it's the most common, and it's all because of that, it's the most well known, is major depressive disorder, which is diagnosed when you've had at least 2 weeks of a couple of symptoms, 5 symptoms to be specific. And one of them has to be that you're either sadness or depression as the symptom that I just covered, right? Feeling down, hopeless. And the other one can be, if not feeling sad, then a lack of positive affect or positive emotions. So this is professionally known as Anadonia, which, I guess it's a cool Greek term, but it basically means loss of interest or loss of pleasure in things that you once found enjoyable and pleasurable. Some of the other symptoms, I can say, there are symptoms that are cognitive, right? That are things that you're thinking, like feeling worthless, having thoughts of suicide, having difficulty concentrating. There are other symptoms that are a little bit more around your body, right? So feeling agitated or slowed down, feeling like your movement has been affected. Feeling fatigue or loss of energy. There's issues with sleeping. So that could be either sleeping too much or not sleeping enough. And similarly, there can be issues with eating. So in either direction, your increased appetite or increased weight, or decreased appetite or decreased weight. And I think I covered them all.
Yes. I think, Lee, I'll add to what Lorenzo mentioned, that if individuals have another set of experiences, in addition to what Lorenzo mentioned that we think of as sort of making up a depressive episode, some individuals will have that at certain points in life, but at other times might have kind of what we would see as the opposite. So for 4 days or 7 days or longer, rather than sort of being low in mood and energy, they feel a lot better than normal. And not just like a good day, they feel euphoric. They sleep less because they don't need as much sleep. They have a lot more energy. These are things that could make up what we would call a manic or a hypomanic episode. And in older terminology, if people at points in their life had both of those, that was what had been called manic depression. That's a little confusing. So now we refer to that as bipolar disorder. I don't think that's what you're focusing on basing on the target questions that you've given us. But I did want to mention that. Whether or not you included, I'm not sure. But that's important for people to know, especially lay listeners, because if a family member or if they've had both of those, that suggests sort of there's different causes of that as well as different treatments that Lorenzo and I would think about that are a bit different than strictly for a depression or a depressive episode, like major depressive disorder, for example.
That's fascinating. I never knew that was called manic depression. That seems like such an oxymoron to me.
Right. And in my experience with students, sort of the misunderstanding that I've witnessed was almost like they took the first word of that to mean like manic depression was someone who had extreme depression. And again, we've had a label change now in our diagnostic manual where we refer to it, and I think more appropriately, as bipolar disorder, because that reflects the up and the down episodes.
All right. Well, thank you. You mentioned a little bit about causes. So in terms of depressive disorder, what causes depression?
Lorenzo, would you like to start with this one?
Well, okay, I'll do this. I'll do the answer is we don't know 100%. A combination of biological, so things that are happening in the chemistry of your body, genetic, which have to do with biological, but also things that happen to you socially in your life, like getting fired, getting divorced, being exposed to other forms of trauma, and then aspects about yourself, how you think, your habits or lack thereof, your propensity or tendency to feel negative emotions. Some people are very, very resistant to negative emotions or just don't experience them a lot. Some people are very prone to experiencing them chronically. Some people have very unstable. So all those things kind of interact to predict whether somebody will become depressed.
Yes, I agree. And I'd add to that another level of analysis that we look at moving from individual is to looking at societal or economic. And this is related to an area of research in psychology and health and medicine in general, referred to as social determinants of health. And we know that there are certain groups and certain conditions. So perhaps the most important of those is low socioeconomic status or living in poverty is a risk factor for depression. And in fact, maybe a bit of an overstatement, but almost everything. Many other psychological disorders, as well as many medical conditions, and individuals living in poverty often, when they have medical conditions and we compare the course of their disorder compared to the individuals who are at higher levels of social position, have worse courses of disease.
Yeah, I would kind of just piggyback off of that to say that a lot of things affect your mood, right? Because depression is a disorder of mood, basically anything that would affect your mood has the potential to move the needle in terms of making you more or less likely to be depressed. I really like Sumner's focus. I'm using your first name. I hope that's okay.
Absolutely, please do.
and please use mine as well. On social determinants of health, it's so important. And so I'll add a couple, I guess, that are more identity-based, but we know that gender is a really big predictor of depression, in that cisgender women and people who are transgender or gender nonconforming are at a much higher risk for depression relative to cisgender men, as well as sexual orientation. So sexual minorities are at a much higher risk. And the situation with race is a little bit more complicated, but Native Americans are certainly at a much higher rate of experiencing depression than other racial ethnic groups. The story, I feel like, gets a little more complicated when you're looking at white, Black, and Latino adults, because white adults are at the highest risk of those three groups of white, Black, or Latino, but Black and Latino adults sometimes have courses that are more chronic or more impaired by their depression. So it's kind of murky, but these aspects of identity certainly matter a lot.
Interesting. So you're saying that there's kind of a genetic or biological component, but it also depends a lot about what's going on in your life and the circumstances that you're in.
Yes.
Mm-hmm.
I think it's very normal for most of us. We go through life frustrations, life stressors, sometimes life traumas, and that impacts our mood, and we might feel down or sad. But I think in this topic of the discussion, we're really focusing on factors that are associated with the development of the full disorder. And as Lorenzo mentioned, major depressive disorder, which is by far the most common or the most prevalent in the general population.
Yeah, I will, by the way, just to put a number on it that we haven't as explicitly done yet, if right now you take a random sample of people in the United States and you ask them, over your life, have you had these symptoms, you would get that roughly 20% of people are going to remember. So using the data from the NESARC-3, the number is 20%. So that's kind of a rough estimate. Because a study like that, and there are several like that kind of converge around this 17 to 20% number in the United States, at least. One limitation of those kinds of studies is that you're asking people to think about their whole lives, right? Which is really hard to think about, every 2-week period in your life that you could have met. In studies that use more sophisticated methods and follow people repeatedly over the life course, the rates look a lot higher, like anywhere from 30 to 50% of people may have a period that met this criteria for depression. So this is something that is very common and can be very impairing, but it can also vary a lot between people. So for some people, it can be this 2-week episode where it's really bad for you, but you're able to recover and get on with your life, maybe never experience another one, maybe even forget that it happened, right? Whereas for other people, it can be this very chronic, unremitting thing for years and resistant to treatment. So it kind of varies a lot.
Mm-hmm. I'd like to dovetail on that also. Those are really important parts that using the manuals that we do in mental health, when we make the diagnosis, it's generally in a binary fashion. People have the disorder or they don't. They have major depressive disorder or they don't. But we also attempt to quantify the severity of the disorder, which Lorenzo was just, I think, in part clarifying, that when people meet the criteria, and it's 2 weeks or longer, and the experience is deviating from their cultural norms. So as a maybe a clear example, if someone has had a death in the family, loss of a loved one, the symptoms are almost identical for bereavement and major depression. But in that case, at least initially, we would not make the diagnosis of major depression because that's a normative experience. Having those same symptoms is quite normal for many, if not the majority of people. But then we also look at getting at the severity, how much it impacts people's distress, how much distress, and then how might it impact their functioning. And at the mildest end of a major depressive episode, someone might be miserable on the inside, but still fully functional with family, work, their other activities. And if they don't share with other people, that they're sort of smiling through it, other people might not even know the struggle they're having. But when a major depression is at sort of at the moderate or the severe end, kind of by definition, that's causing some degree of impairment in functioning. So perhaps a student who had been high achieving and a 4.0 or close thereof goes into an episode and now their grades are a 2.5 or a 3, or they're missing work a lot, or at the most severe end, they might not be able to engage in those activities at all. They might not go to work and get fired, or make a suicide attempt, or require psychiatric hospitalization, which would be brief and needed in the most severe cases, or potentially needed anyway, for stabilization. However, the majority of individuals receive treatment on an outpatient basis, which we haven't gotten there yet, but I'll toss that out.
All right, well, since we are talking about treatment, what forms of treatment are there for people with depressive disorder?
Well,
I'm going to defer again to you, Lorenzo, if that's okay.
Yeah, of course. No, I appreciate it. So I really care. I think I was alluding to this idea that there's a range of depressions. Kind of one way of thinking about it is like mild to severe, but of course, it's not just about how intense the person's symptoms are. It's also about how long they've lasted, and it's also about whether this is a first or second episode. I think some specific symptoms also can make it a little bit more complicated, right? Like suicide, or if the person is hearing voices or seeing things, that can be a complicating factor. But just like there are all these ranges and all these dimensions to how you can be depressed, there are all these different pathways to recovery, right? So a lot of people can, again, this would probably be more the milder end, but can get better on their own, right? Like their symptoms just kind of spontaneous. We call that spontaneous remission. So remission is the symptoms went away. Spontaneous meaning we don't have an explanation for why, it just kind of happened. I think a lot of times when there's a life event that's happening in someone's life, you can kind of see, oh, you were depressed for X reason, and then X reason is gone. So maybe that's the cause. But we don't have as much research on that as I would like there to be. But so that's one end. My lab studies, for example, interventions that are brief and scalable, like, for example, reading books, using internet apps, using apps or books with the help of a professional who can kind of walk you through it a little bit. So those are kind of some, I call them low intensity interventions, right? Because you don't need a professional to be with you for weeks or months on end. You can kind of do that on your own and with their help. The thing that I'm also a specialist in is psychotherapy. And I should have said in the beginning of the talk that in addition to being a professor at Indiana University, I also see patients on the side. So I'll have anywhere from, depending on how things are going, anywhere from 2 to 6 patients every week. And what most people call talk therapy usually involves, in the past, before the pandemic, most of it was sitting down face-to-face with a person. And psychotherapists, they practice therapy in different ways. So we call those kind of schools of therapy. And really, they don't differ, they're not different so much in the format. A lot of the format is very similar, sitting face-to-face for a couple of weeks. It differs really in terms of what happens in the session. So in the way that I was trained, for example, we try to think about what are things that we could do right now to help you with your mood? What are behaviors or actions that you could do differently, and also ways of looking at the world that could be different? If a person was trained, for example, in psychoanalysis, they wouldn't necessarily be so focused on that. They may be more focused on thinking about your development and your very early development. If a person was trained, for example, in interpersonal therapy, they would focus more on the social relationships. So the format for psychotherapy is kind of the same, but what happens inside the therapy room is going to differ a lot based on how that person was trained. There's a bunch of biological interventions, right? So there's a lot of different medications. The class that most people would know are antidepressants, which are called antidepressants, but they kind of work on feelings of depression and anxiety kind of generally. But there are some medications, for example, that are typically used for mania and bipolar disorder that are sometimes used to add on to the medication, or that are sometimes used for psychosis and schizophrenia, but they can add to the efficacy or how well the medications are working. And then there are all these other interventions, which I don't have a good expertise in, that are physical, but they are not pills. So for example, things like electroconvulsive therapy, deep brain stimulation, transcranial stimulation, they're kind of acting on your body and your brain specifically. And usually in cases where people have failed multiple interventions and their depression tends to be more in this end where it's severe, but also it hasn't really moved around on its own, or certainly with treatment.
I think it's an excellent answer. And I agree fully. And I'll add a couple of things, again, thinking about your target audience that you had mentioned for the podcast. The first is that in this day and age, for individuals who pursue talk therapy, or we also refer to that as psychotherapy or mental health counseling, those all sort of mean the same things. Those are generally shorter term. So it might be several sessions, maybe once a week over a month or several months, but not something that's going to go on 5 or 6 years for almost any cases. That would be true. Treatment is often focused on symptoms and shorter term like that on an outpatient basis. So going into an office, as Lorenzo had mentioned, like when he sees patients, they come in the office, there's 2 chairs and they sit and talk. Sometimes there's a misunderstanding. I think this is perhaps due in part to sometimes how the mental health professions are portrayed in television and movies, which for the most part isn't so realistic, where someone's sitting down on a couch. Well, that was how therapy was done by Freud, who sort of credited as creating psychotherapy. That's psychoanalysis. But that's sort of gone the way of the dinosaur. Different schools of therapists now, it's 2 chairs, it's being comfortable with your therapist or your helper in a room, and sessions might last anywhere from 30 minutes to an hour. Another area I would mention, and this is a little bit more one of the things that I've studied in regards to depression and health, is that there is an enormous amount of research also on the impact of physical exercise as depression. And in addition to mental health counseling or talk therapy, the different biological techniques that Lorenzo mentioned, either medications or some of the ones that are a little bit more novel, like the magnetic resonance of the brain and things. Physical exercise has a really robust effect. And it's been studied across many different samples, individuals with many types of depression or levels of depression. And it's highly, highly effective. So if someone was feeling down or maybe even worse, sort of feeling depressed, like an episode like we mentioned, and is not exercising regularly, that's something that they could do on their own immediately that would have a pretty good likelihood of having a positive impact.
Yeah, and I'll just piggyback off Sumner. When we're talking about any of these recommendations that a person could do, like, they could try therapy, they could try medication. In a lot of the samples that we have, when a person tries something, there's like a 50-50 chance that it'll work. For many people, and again, a lot of these samples, people are seeking treatment, so they already kind of know that it's more severe than if they could handle it on their own, which most people initially think that they can. But a lot of people need to try multiple things. They need to try multiple therapists. They need to try multiple medications. Maybe they were trying exercise, but that wasn't helping on their own. But then they got a therapist, and the therapist helped them adhere to the exercise a little better. And so the therapy and the exercise help. So it's any of these things are maybe higher or lower likelihood that they'll try, but nothing is 100%. I'll say that. I'll also say one of the things we didn't mention that I wish we would talk about more is group therapy. Group therapy for depression has been studied a lot. Groups cognitive behavioral therapy, which is the kind of therapy that I practice, has been shown to be just as effective as individual face-to-face therapy in so many studies. We have a lot of data that people don't like going into these group settings. And so the group therapy tends to have the lowest rating that people say they're willing to try compared to psychotherapy, using internet apps, reading books, going to even a lay counselor. Group therapy is not very popular, but it's just as effective as individual therapy.
Okay, so you've mentioned a lot of treatments. The low intensity that you mentioned, like reading books. You've talked about therapy and the different kinds of therapy, exercise, medications like antidepressants. Starting with what you said about reading books and interventions like that, why does that work?
I mean, it's a little bit of like the question. I'm sorry to jump ahead in front of you, Sumner.
No problem.
But it's a little bit of like the question of what causes depression, right? We don't really know that well enough. Now, it could be possible that depression is caused by one thing but cured by another, right? That the thing that starts it is not the same thing as the thing that keeps it going. But just like we don't know what causes depression, we also don't have like a great handle on what gets people out of their depressive episodes. I have, for example, an interest in the way people think, right? And whether when they're feeling down, they're able to look at things from a different perspective. And there is some data out there that correlates how you're thinking and how your thinking changes during treatment to how you're feeling better. So usually during treatment, people may learn just ways of reacting to things that are not as negative, that are a little bit more productive. Sometimes that happens because your therapist is directly helping you to do that. Sometimes it happens because, you know, you go out for a run and you feel better. And then once you feel better, you start kind of looking at things from a different perspective. So the direction of causality, or, you know, is the thinking the only thing that needs to change? That's a little bit less clear, but the way you think seems to be a component, as well as doing new things, I think in general seems to be a component. Sumner maybe can talk to us about doing physical things specifically. But that would be my those would be kind of my contributions as to why those interventions work.
Absolutely, and I'd like to add to that that within our field, especially within clinical psychology, there has been decades of debate as to why psychotherapy works or which of these schools is better. Another really important predictor of success, so this is true of mental health counseling or talk therapy in general, as well as for depression, is there seems to be a really strong impact from simply the client-therapist relationship themselves, that there's something special, I'll say that, powerful or impactful from a scientific perspective. The non-scientist in me, who also does therapy, would say it's magical. It just so happens that we can explain that from phenomenon of humans in the natural world, that is predictive of people coming in to see a professional, like a psychotherapist, and that the nature of the relationship is powerful and very catalytic for change. I think that factor, and then especially for depression, individuals making changes in their patterns of thinking and their overt behaviors, we sort of put it all together. We think about that, or some anyway, think about that as sort of the total package and what might make therapy most impactful for depression. I think, Lorenzo, this is more your area of research, so I'll maybe introduce it and then toss it over to you, which is not everyone can see a therapist. They can't access it, or they don't have health insurance, they can't afford it. And one of the nice things with the internet and our field has slowly been sort of what's described as the democratization of mental health services. So there are protocols and treatment that are available online, some of those for depression with minimal therapist contact, some of those with no therapist contact, and those are pretty well studied and shown to be effective. Can I toss that over to you, Lorenzo?
Oh, of course, no, and I really appreciate that, because I love talking about that. There has been a lot of work, and I like to think about it sometimes as like, you know, we're at a university, right? And so there's work that's been done at universities, and sometimes that overlaps with work that's done in industry, right? Like people who sell mental health apps, technology startups, several different corporations. sometimes there's a nice overlap, right? Where the things that are being sold to us on the App Store, or even if you think about self-help books, that there have been studies, like my lab right now is doing a study of a self-help book, right? That where we give it to people, we give them a little bit of guidance and we track their symptoms. So sometimes there's just not nice overlap where things are being sold and this kind of profit is being made by somebody, but there's a good science backing to what's happening. Then there are these other times when people, because it may not be as well regulated, develop their own mental health apps. And those are not always as well studied. Just like any person could self-publish a self-help book and say, like, I think that depression comes from not eating enough cheese. And if you just have enough cheese in your life, and it's and nobody's saying you can't publish that book, right? You could just write it as your opinion. But I think that there's a lot of material out there and a lot of it has a lot of evidence to it. But there's also, I think we have to also be on the lookout for some of it not being as evidence-based. So you can, professional organizations, and I think, Lee, we can give you, hopefully we can give you links that you can attach to the podcast, because some professional organizations have like lists of apps that have been well studied.
Yeah, I would love to have any links that you can send me, and I'll make sure for the YouTube video, I'll make sure to include it in the description. And then for the transcript, I'll put it just at the top.
Great, awesome.
Thank you. So I've heard, and sometimes when people try to describe what depression is, they say, aside from the social factors, they'll say that it's kind of like a hormonal imbalance in your brain or something like that. If we could talk about the slightly more biological side for a moment, how does depression affect your body, either through the symptoms or, I'll just leave it at that. How does it affect the body?
You want to take that one, Lorenzo?
Well, I can be very negative on this point, so I want to let you go first, maybe, and then if I have something constructive to add.
Sure. I think, Lee, I'm going to be brief because this is not my area of specialty. But I think it would be accurate to say that from the biological side of things, we know that there are certain changes in the brain that are associated with depression. So, for example, neurotransmitters of serotonin and norepinephrine. There's also theories that.
Could you say what serotonin and norepinephrine is real quick?
Yeah, sure. So those are neurotransmitters in the brain. So those are basically chemicals in the brain that are part of messages being sent, which is both by sort of electrical stimulation as well as chemicals in the brain. So there's some beliefs that dysfunction in those two neurotransmitters might be risk factors or causative factors for depression. I'm not sure that is fully supported from the kind of studies that would be needed, which would be numerous long-term longitudinal observational studies or prospective studies with large groups of individuals, some who didn't have the disorder and were assessed for the factors we've been talking about, social and individual factors, as well as having biological factors like neurotransmitters measured, following them for years to see that some of these individuals would develop depression, and then see if those neurotransmitters are a risk factor. I think that's a little bit more debatable, possibly true, but I'm not sure even in this day and age with some great biological research that is truly supported. And
oh, did I cut off? Oh, he cut off.
Yeah, I think he's frozen.
Oh, this can be one of those parts you cut out.
If I have anything in this podcast completely wrong, please feel free to say, hey, that's completely wrong.
Well, I mean, I was gonna say that about this biochemical theory. Sumner, it seems like it's saying some version of this, and you're back.
Yes. Yeah, so yeah, I was basically at the end of my thought. I'm on campus, but the internet is unstable, so sorry for dropping out there, but please take it away from there.
Yeah, maybe I was going to be maybe a little bit stronger that if you are saying this very, very simple idea, there's a group of people over here who are depressed, there's a group of people over here that are not depressed. If you can measure their brain chemicals overall, you'll find this group has a higher and lower level than this one. I think that just the existing research on that just doesn't support the idea that it's that simple, right? That it's just one chemical went wrong and you can see it all over the brain. You know, I think, and again, this is not my area, so I take this with a grain of salt, but you know, different neurotransmitters may be more or less common in different areas of the brain. And then I do think we have research on maybe activity in the brain be in certain parts of the brain being stronger or weaker in people who are depressed, as well as maybe the volume of certain brain areas being stronger or weaker. For example, one of the things that I feel a little bit confident about is this idea that over the course of psychotherapy, if you are measuring people's brains like before and after psychotherapy, as a part that becomes a little bit more active that's known as the anterior cingulate cortex. And this is a part of the brain that in other research gets activated when you're trying to like control your emotions, when you're trying to like regulate your emotions. So you could say, oh, well, it's the anterior cingulate cortex then, and it must be that thing that causes depression. But it's not that simple for the reasons that Sumner stated, right? And again, this is a confusing and maybe a little bit pedantic point, but the things that cause depression are not necessarily the things that get you out of a depressive episode. And so just because something gets better with treatment, it doesn't mean that that is the thing that is problematic in depression. If you think about it, I think the silliest analogy to this is saying that, you know, people have headaches because they're not taking aspirins, right? Because once you take an aspirin, the headache gets better. Well, that doesn't mean that was the cause of it, right? And I know you weren't saying something so simplistic, but sometimes people have this very simplistic attitude of like, oh, depression is just caused because your chemicals are lower, and then you take a pill and they get higher, and so that explains the whole thing.
Okay, thank you. That helps a lot. So it seems like we should focus a lot about the social aspect and kind of the circumstances that a person is in when they have depression. I should have asked this earlier. How do you recognize when somebody's in those circumstances and they're feeling depressed? How can somebody realize that they need help from maybe a therapist or with those interventions that you mentioned earlier? How can they realize they need that help?
I think one of the things I would point to, most people, if you ask them, if they're not in therapy and you ask them why they're not in therapy, there's all these questions about like stigma, accessibility, like barriers. All of those things definitely play a major role in the United States. But we actually look at what people most commonly say. What they will say is, I want to deal with this problem on my own. I think I can do this by myself without a therapist. I think I just want to talk this out with my friends and family. So I tend to actually believe the things that people say. And I think that at least when people say that to you, there's a big grain of truth. So to me, one of the things that would let a person know that they need treatment is if they've tried those things and it's just not going anywhere, right? So that to me is a red flag. You know, when it starts affecting areas of your life, the most common way that people feel that depression impairs them is usually like internally, like I feel bad, like this bothers me. A lot of people are able to feel depression and kind of keep working, maybe taking a hit to their productivity, maybe taking a hit to how happy they are while working, certainly. But for a lot of people, it affects their social relationships, right? And so I think when you're starting to notice that it's interfering with your ability to engage with your loved ones, that it's interfering with your ability to work, that could be an indicator that maybe you need help. But I really want to say, I think psychotherapy is great. There's a problem in this country that we don't have enough of it, that we need more people who are trained to do therapy at different levels. So not everybody needs to get a PhD like we did, or even a other kind of doctorate, or maybe even a master's. We need to have different professionals who can provide different services to people depending on their needs. I just don't want to make it seem like I'm saying, well, only if your depression is really, really bad do you need a therapist, right? We don't yet know who the kind of person is that their depression is going to get better on their own, or with an app, or with maybe a support group, versus who needs a therapist and who needs medications or electroconvulsive therapy. So it's a little bit of this mix of like how you're feeling and how it's affecting your life, and kind of like trial and error, right? Like if you already tried a lot of things, then going up to different professionals makes sense.
I think I would like to add to that some aspects of this, which I don't think are mutually exclusive of what was just mentioned, but we're very complicated as human beings. We're complicated animals, and there's a possibility that we have these different symptoms or possibly have this disorder, and then there's also how do we feel about that? If we do, can we accept that? Is that scary or potentially psychologically threatening to think that something is wrong with me? And those sorts of thoughts, and that process occurs at an individual level, but is impacted by groups and society. So for example, if we went to a country that had no psychology, no mental health professions, they're not going to believe, most likely, that going and talking with someone is going to make a difference. It's a concept that's just absolutely foreign to them. And I think, for me anyway, that adds a little bit of complexity, because sometimes that analysis of like, I really am suffering or I really am hurting, people might not really want to think about that, or it may for them be really threatening, so they don't often acknowledge that. They might sort of consciously suppress that because it's a scary thought. And so there's that complexity. I think the more open we can be as a society, and the more that we can all be educated to understand these different problems, and also be aware that there are these treatments that to some extent are quite simple. I mean, when we talk about seeing a therapist or mental health counselor, you go to their place, you talk for 30 minutes, an hour, most likely it's once a week. You do that for 8 or 12 or 20 sessions, 8 or 12 or 20 hours, plus things you're doing on the outside to change. And that's really, really effective. I mean, again, that's the part where, to me, it's almost not a good science. It's just that's sort of magical that really works, and works as well as medications, if not better. There's some debate about that.
Yeah, and we can talk about that confidently, just because there's been enough research that at least the psychotherapies that have been well studied, like cognitive behavioral therapy and interpersonal therapy, they seem to work almost like at the same level of medication. There's a couple of studies where medication have a little bit of like an edge at the end of treatment. My interpretation, or the way that I think about those, is psychotherapy varies a lot, right? But by the therapist, by the patient, and their combination. So I think there's more variability in the outcomes that of therapy, but on average, they're kind of on top of each other. Therapy has a big advantage when you actually look if a group of people are on medication versus on psychotherapy, and then they just continue. The people who had therapy usually have better outcomes than the people who abruptly discontinue medications. And therapy sometimes is better than continuing on medication. So Pim Kuipers and Steve Holland have a meta-analysis about this. So I think I'm a big fan of psychotherapy for this reason, right? That it seems to have this effect that whatever all happens seems to be more durable than taking a medication. But the most durable thing is doing both. And that's confusing, right? And so I'm saying, well, on average, kind of therapy is better, but actually doing both is better over the long term as well.
I'm in perfect agreement with that. And let me add, Lee, again, for individuals who might listen to the podcast who haven't seen a therapist before, or this is sort of the first time they're hearing this level of detail about these things. The choice, assuming that they could get to a physician or get to see a mental health counselor, is really theirs. So people can get therapy, or they can see a physician for medication, or both. Like Lorenzo, I do a small amount of private practice on the side. And so oftentimes, why are they getting therapy? It might be because they have a physician in town who's more psychologically minded, knows about the research, knows about cognitive behavioral therapy. They had an annual meeting or something, and they told their doctor that they were depressed, and their GP, their general practitioner, maybe said, why don't you start out trying therapy? Here's a few people in town who do it. Other physicians might immediately just write a prescription. But anyway, both of those options or a combination are available for individuals, in part depending upon how they would like to proceed if they want to get professional help.
Both of you mentioned a little bit about trial and error when beginning these interventions, trial and error with the therapist. How would you go about finding the therapist that is right for you? How do you know if a therapist is right for you?
So Sumner, not to keep jumping in, but Sumner mentioned this point that I feel kind of ambiguous about. But if you're going to go with the data, right, this kind of relationship that you feel with the therapist actually quite early in treatment, I'm talking sessions 1, 2, 3, 4, 5, like that early, is a reliable predictor of outcomes. It's not a huge predictor of outcomes. But it is a reliable predictor of outcomes. The one thing I will say about that is, I think sometimes people interpret that to mean like, oh, if I think that my therapist is cool and they're smart and they're nice, then that means that we have a good relationship and I'm going to get better. People's, how they rate, how they're like their therapist usually also has to do with what their therapist is telling them about their depression and what they're planning to do. So there has to be also like this kind of agreement on what are we going to work on? What is it going to look like? What should I expect out of this? So, to me, if you had a therapist that you liked because you thought they were nice and fun to talk to, but you didn't agree with anything that they were telling you about how you're going to get better, that's not a good fit, right? It's usually the things have to go hand in hand, that you like them interpersonally, but they also kind of you agree with them on the goals of the therapy. And the only reason I'm saying this is because most patients, if you ask them questions like, hey, do you like your therapist? Would you, if you didn't meet them outside of, if you didn't know them as a therapist, do you think they'd be a good friend? Most people will write usually like, oh yeah, and if you give them a 1 to 10 rating, they'll be at the 8, 9, 10 range. There's a little bit more variability with like, do you agree with the things that are happening in the session? Do you think that these are the types of things that will make you feel better, right? So if somebody has had you for 5 sessions talking about your family of origin, and that's not a thing that you're finding helpful, to me, that would be kind of say to you, oh, there's a disagreement that needs to be resolved. And a lot of times they can be resolved. You can bring it up to the person and it can be resolved. Sometimes it means you need another you may be a better fit with another therapist. But I think that personal relationship is a good indicator of how things are going to go.
Mm-hmm. And hopefully from research that investigates the behavior of the therapist and how that impacts the outcome of the client, the therapist would be engaging in sort of some of the basics, checking in with their client about how the client is feeling and about the relationship. Like, we've met 5 times. How do you feel like we're doing together? How is the treatment going for you? So I mentioned that in part to just let you know that within psychotherapy research, things can get quite technical when we're looking at the outcome of the patients and specific therapist behaviors and patient perceptions of the warmth and belief in the treatment that they're getting, et cetera. I'm not sure for the public how interesting it is that really lights up Lorenzo and I, sort of that level of detail to look at, sort of again, at specifics of human interactions that are making these differences for patients with depression.
That's fascinating too.
By the way, I will also add, just because Sumner is bringing up the literature, which I'd really like, one thing that is a really boring but true thing about psychology is that a really good predictor of the future is the past. So something that could tell you whether you're going to have a good outcome with a therapist is if the first couple of weeks that you've been meeting with them, you actually already are starting to feel better, right? So that usually that predicts that you feel even better after that.
Wow, I didn't know that it could happen so fast. That's awesome. Forgive me for jumping around a little bit, but we also talked a little bit about stigma and kind of the fear of admitting that something's wrong with you and that you need help. How can we get rid of the stigma and fear? How can we help people be more open and access these resources?
If I could start with this from Lorenzo, in part just because I'm going to have to go in within about 7 or 8 minutes. And I'll start quickly, just a little bit historically. So traditionally, there has been a really significant stigma in regards to mental health, the disorders, acknowledging that one has the disorders and how that impacts treatment. And there's a couple of things that historically are probably noteworthy. One of those was that the president, after Nixon, when he waved goodbye and told us about his dog Checkers and resigned, and Gerald Ford came into office, was his wife, President Ford's wife, had a really severe alcohol problem. And after he was out of office, she went public with that. She outed herself about that. And in fact, there's a treatment facility in California, which is the Betty Ford Center. And I think the more of those sorts of things that happen, the better. This is anecdotal on my part, so I'm moving away from the research, but given my age and how long I've done this, I think sadly with 9/11 happening, one of the sort of societal outcomes was that I think there was some greater understanding by the general public about post-traumatic stress disorder, and also I think stigma. If someone were to meet an individual who had been a rescuer who survived that day and was told, they said, after that, I developed post-traumatic stress disorder, I think most people would A, have a basic idea what that meant, and B, probably be accepting and not judgmental that person had a weakness. And I think the more that these sorts of things are made public, and part of that is our responsibility as mental health professionals to try to educate the public, the better. I also think at a more informal level, the more that individuals who are in the public eye go public and share their struggles that they've had, whether with depression or other mental health problems, the better. So I was just sort of jotting down a few. So Beyonce has been extremely open in interviews talking about episodes of depression, maybe a problem called agoraphobia, where she wasn't leaving her apartment for months, weeks or months on end. Harrison Ford, so the actor who played Indiana Jones in the movie, he was afraid of snakes, long history of both social anxiety as well as depression. The Rock, Dwayne Johnson, I mean, you wouldn't imagine that guy would have struggles with depression, but he has. Bruce Springsteen, one of the original rock and rollers, published a book a few years ago that he's had therapy for years. I'm not an auto racing fan, but I've gotten into Formula One from the Netflix show. Toto Wolff, who's the head of the Mercedes team, who's dominated that sport for many years, just shared in the past couple of weeks that he's been having once a week therapy for years, psychotherapy. So I think the more that people share those sorts of things, the better, to help us in the public understand, like, there's nothing wrong with me. Like, if those folks are having it, right, certainly it's okay for me. And also to find out that people are sharing about that intervention they got was successful, to normalize for all of us that this is okay. We would hope not to have it, but it's okay if we do. and that treatments are available and they're highly effective.
That's awesome. That's such a good point to mention. And it made me think about two others. Carrie Fisher also, I think, was very open about struggling with bipolar disorder and substance abuse. More recently, Britney Spears have talked about having social anxiety and depression. So there's just so many people. My understanding of the stigma literature is that you feel stigma or ashamed of things a lot of times when you think that it's things that are not normal, right? And so I think that's part of the reason why talking about it is important. I know I've had two periods of my life where, in one of them, I actually did get assessed at the Cognitive Therapy Center in Philadelphia, and I had a mild to moderate depressive episode in graduate school where treatment helped a lot. And then I had another one a couple of years after when I was having kind of severe chronic pain, and I was on clinical internship. And that one I took medications for, and it was partially for the pain. Some medications treat both pain and depression, so it's a little confusing. And that really helped a lot. And right now I'm not doing either of the things, but those were times that I really benefited a lot from treatment, and my understanding of psychology, I think, gave me a little bit of motivation to pursue treatment. And even as a mental health, as a person who has done therapy, I still back then and kind of now saying it, I'm like, oh, should I have said that? You know, and so I think the stigma about these things is just very pervasive, and it's not good.
Mm-hmm. I think that's an important share. I appreciate your mentioning it, and I've certainly had my struggles and sought help in the past. And I do think it's important for us who work in the profession to share that. I think sort of as a final thought to the listeners, Lee, I might mention either someone's thinking about themselves or they have a friend or someone in the family. Sort of a question I like, or one way that I think about it is, if they're feeling really depressed, you don't have to feel that way. You know, treatments are just so effective and they're so varied. And you know, I think hopefully for someone who's listened to the podcast, maybe if that's an issue or it's in a loved one, they can supportively think that to themselves and seek treatment, or mention that to the loved one, and hopefully they'll, you know, consider seeking treatment.
I love that point as a point to end on, in part because I also have to go soon. But, you know, in the STAR-D study, which a lot of people like to criticize, which was a study of medications that was done all across the United States. It has 4,000 people. People were given multiple treatment options. Well, at the end of 5 treatment options, roughly 70% of people got better. That's a high number, right? It's 70% is a lot more than 30, which is what happens if you only give one antidepressant. And the World Health Organization, the World Mental Health surveys also, if a person has tried up to 10 treatments, there's like 100% likelihood that they'll get better. It's like 99. It's very, very high. Most people kind of drop out and have a hard time getting back in the system, in part because depression is a problem about being amotivated and maybe perceiving that things aren't going to work out, in part because it's just so hard to get treatment. But if you stick with it, you will get better.
Mm-hmm. I think one final thing I will add, Lee, is for individuals, if they don't have health insurance, you know, that they hopefully could get involved, possibly if they can get registered through the public mental health or the public health system in their state, which would be Access for us here in Arizona. But a plug for cities that have universities, which is if there's a university that someone lives near and there is a graduate program, whether master's level or doctoral, and there's many different types of mental health professionals. So it might be clinical psychology or counseling psychology, or a master's in clinical mental health counseling, or a master's in social work. Almost universally, these programs have in-house training clinics that serve 2 purposes. One of those is to serve the community, and the second is it's the training site for the graduate students themselves. And research indicates that that intervention with graduate students is essentially just as effective as seeing someone who has a doctorate out in the community, and that would be low cost or no cost. So especially if individuals don't have private insurance or can't find other resources, that can be something to check into.
That's a great plug.
That's great. Thank you so much for sharing your experiences, for sharing your information and the resources. I think that's wonderful. And thank you both so much for participating. I know personally I've learned a lot today, so I'm very grateful. And yeah, thank you so much. I'll stop the recording now.
Okay, you've done a